Oh, hello everyone. Social distancing is over. Well done. Welcome to the grand round today. For those of you who don't know Michelle, this is Michelle Liu. She's one of our wonderful registrars who's been here forever. And she's been volunteered to do this talk, and she's very graciously here to do that in between studying for exams. So please be very, very, very. So despite all the wonderful care that Royal Perth does to trauma patients from the moment they enter the door to the moment they leave, and with all the subspecialty input in between, sometimes it would be nice not to do it perhaps quite so much. So with our sort of public health hats on, Michelle's going to talk to us about one of our programs to try and prevent or flatten the curve of trauma presentations. So I'll hand over to Michelle to tell you about the PARTY program.
Hey everyone, yes, I'm Michelle Lowe. I'm one of the registrars here in the emergency department, and I've been volunteered by the emergency department to do the talk today for Shore Grant. Now, what we're going to talk about today is risk-taking behaviour and injury prevention programs, and we're going to specifically talk about the one that we have in this hospital. It's very much part of this hospital. It's been here for like longer than my entire career, and many of ours as well. And it's called the PARTY program, which is Prevent Alcohol and Risk-Related Trauma in Youth program, which is more catchily known as the PARTY program. And it aims to change the perception of youth to say that, like, look, I'm about to enter an age where I am at risk and I take risks, and we want to change the perception of those people that trauma doesn't happen to them. Unfortunately, during COVID, this program hasn't been running. So unless you've worked at Royal Perth or Midland Hospital, which is the other place that has a PARTY program, you might not know about the program, in which case, great, this talk is for you. You'll find out about a PARTY program. And for the people who already know about a PARTY program, because both the trauma team and the emergency department play a large role in running this program, hopefully you'll know a little bit more today rather than just trying to make as many people faint as possible in the day, which is generally what we try to do. So the things that we'll cover today, we're going to have a quick look at the burden of road traffic injury, both globally and locally. We're going to try to work out who is at risk. We're going to see whether we can do anything about this risk, and then we'll see whether it works. So we'll go through a little bit of the evidence for it. And there's people in this room that have written the papers, so they can comment. And it's a little bit like teaching people to suck eggs, but we're still going to have a look because it's really important to know. So these stats are from the World Health Organization report on road traffic injury prevention, which is actually a good thing. These global stats are a little bit old, so they're from 2004, but they're the most recent global stats that we have. So it represents 12% of the global burden of disease and the main cause of death in young people, so less than 40-year-olds. 25% of this is counted by deaths from road traffic injuries in injury umbrella. And road traffic injury is the third leading cause of disability adjusted life years lost, so DALYs. The cost is estimated about 2% of the global gross domestic product in specifically high income and highly motorized countries like, for example, Australia. And the mean length of stay is 20 days globally for this. The thing to note, though, for the global number for the disability adjusted life years lost is that low income and middle income injury, countries actually account for 91% of all of those lost to road traffic injuries worldwide. Of course, all types of road users are affected by road traffic injuries, but 50% of global mortality is due to road traffic injuries in young adults between 15 to 45 years old. In high-income countries, 15 to 29-year-olds have the highest rate of injury, and men account for a large proportion of road traffic injury deaths, about 3 times more than females, and like 73% is the number, and it's still from this the WHO report. For all that I've said about like middle income, low income, and high income countries, men still account for the most independent of any income group or any age group. And it's probably due to exposure factors and risk-taking behavior. So exposure factors, as in more men drive Huawei than women do for like cultural reasons and economic reasons in low-income and middle-income countries. And Africa and the Middle East have the highest rates of mortality from road traffic injuries. So 60% of Delhi's dust globally is due to road traffic injuries in young adults. Know that. And we're going to have a look at some local figures. So this is from 2018, and this is the Road Safety Commission summary of fatalities on Western Australian roads, with some very nice graphs, which I quite enjoyed. So there was a total of 161 deaths in 2018 on WA roads. They did split it by region, age, sex, and all of those things, but we're just going to look at a couple of specific ones that we're interested in today. So the most common age group for fatalities is the 20 to 29-year-olds, which account for 25% or 40 of the 161. As you can see, there's like a spike in the graph over there in their age group. 75% of the fatalities were male, so 121 of the 161 people who died were male. And you can see the split between sort of the regional and metro areas over there. So that's that. And the next thing that I wanted to look at from the stats that we have available from 2018 is that like 62%, so a reasonable amount of the fatalities were a result of crashes with recorded driver behavioral factors. Fatigue is one of them, and it's probably like the lowest proportion. Inattention, I know they've said inattention, but I find it very interesting that I put a mobile phone there. Is also like a proportion, but a little bit less. But the things I wanted to look at were use of alcohol and use of speed, in not specifically methamphetamine, because they didn't have drugs in this, but speed as in going fast, which is a reasonable factor in the fatality that we see in WA. So that's the stats from the Road Safety Commission, and we're going to have a look at a little bit of the stats that we have ourselves here from the Trauma Registry. So thank you for the girls for giving me these stats. So I had a look at the Trauma Registry data from last year, so all of 2019. I had a look at all of our MVAs with a injury severity score of more than 15, which is major trauma. And the total number of that in 2019 was 97. As you can see there, I've like sort of stratified by age in decades. So everyone less than 20 and everyone more than 80 in between is just by decades. And you can see that if you're under 30, you make up about a third of all of the MBAs with major trauma that had to be admitted to our trauma unit. And so that's that. In terms of gender, a lot of MBAs of major trauma are male. And this is all comers, so this is not specific to an age group. And we also have stats about alcohol use in the last 24 hours. And so it makes up about a quarter, so the 24% there, which is comparable to the fatality data. And then I thought we'll have a look at gender and alcohol use. So if you can see there, alcohol is the blue bit and the green bit is no alcohol, and male and female, as you can see. So the comparison figures is that essentially 26.5% of men involved with MVA with a injury severity score of more than 15 associate with alcohol use. It's compared to 13% in women. So what I'm trying to say is men are more likely to drink and drive and then get into a crash. And then we had a quick look at the speed factor. So I'm trying to use high speed or inappropriate speed as a marker for risk-taking behavior causing a major trauma. So of the 297 entries, 87 entries, the speed wasn't recorded or not applicable. And so this is the data for the rest of the numbers. And surprisingly, like a smaller amount of it is like associated with speed of over 100 kilometers per hour, and the majority of it's between 60 to 100. And again, I'm just going to compare how likely you are to be male or female according to whatever speed that your MPA is at. So it's roughly equal in the less than 60 kilometer per hour group. Men comprise 59% of the blue bit on the far right-hand side, left-hand side of your screen. And in the 60 to 100 group and in the more than 100 group, men significantly outrepresent women at 81% and 79% respectively. What we can identify from our global figures, the fatality figures, and our local data is that young, especially male drivers, are at risk. And the question is why? So obviously there's many factors to the risk of having a road traffic injury. It's stratified into sort of like 4 elements. The first element is exposure. So it's the amount of movement within the system by different users. So this is sort of affected by demographics, the economic need to travel. So there's probably like more movement in cars in a lower income country than in a higher income country. There's like more use of the road system and land use as well. So the way that we plan roads. The second factor is the underlying probability of a crash given a particular exposure. So if you speed, are you likely to crash? Or if you use alcohol, you're likely to crash, and how old are you? So that's exposures, how likely you are to be in a crash. Then the third factor is that the probability of injury given a crash. So this is the modifiers to that risk factor are like the use of seatbelts, for example, the use of child safety devices in cars. And then the fourth thing is the outcome of injury. So this is related to the structure of St. John's, the structure of the emergency department, how emergency department flows, and trauma calls and trauma units. So that's like the modifier for the fourth thing. So the reason why young drivers are at risk is probably related to the second factor. So it's the underlying probability of crash given the fact that you are young and male. So being a young male is predictive of crash involvement as the driver. And this specific sort of like highest risk time is when you're 16 to 17 years old and or in the first 12 months of having your license. The sort of like postulated reasons for these are as follows. So essentially the mobility patterns and vehicle characteristics, meaning that like, you know, you've probably just entered into a workplace. You might be working at night because you have school in the morning, or your vehicle is really likely to be borrowed or something that's like not yours and you're not familiar with. Psychological characteristics, which what we're going to talk about today with injury prevention programs. So you're like, you know, just becoming independent, you want greater independence. You've got a new skill like driving. You want to be accepted by your peers. You want to like work and have money and be able to spend it. You're probably thrill seeking, and with this greater independence and wanting greater independence, you also have a like overconfidence. I'm sure we can all remember when we're like 15, 16, 17 years old. Just remember what you were like. In this age group, there's less tolerance of alcohol. So crash rates for male drivers aged 16 to 20 years old are 3 times the estimated crash rate of those more than 25 for every single blood alcohol level, like in 0.05 increments. And excess or inappropriate speed. That's the last one. So we know that these people are at risk. And the question is there anything that we can do to modify this risk factor? Well, we've got something that we do in this hospital, where we've got the PARTY program. And it's been running for a really long time because Monica brought it here 10 years ago, something like that, from Canada. So it's very much part of the fabric of this hospital. It's been around for a very long time. We've all probably done a little bit of party before. And I would like to invite our party coordinator, who's Kath Blackman, to tell us a little bit more about her program. Thanks, Kath.
Thank you. All right, so Keep Calm and Party is what the day is all about. So there's me, there's Kelly, who's up the top, who is the part-time clinical nurse, and we've got Lillian, who is our admin. So for this morning, I'm going to tell you a bit about what it's all about, what the background is, who it's for, and just a brief structure of the party day. Started in 1986 with an ED nurse in sunny field in Toronto, who was concerned with the amount of youth coming through that was preventable into the ED department. Took her daughter and a few friends into the ED to show them the realities of what was happening. Progressed from there, Monica Goff went over to Canada for a year, discovered Party while she was there and brought it back to Perth, where we started in 2006. So we were the first base out of Canada to start up, and the first international one as well. Since then it's spread. There's now over 170 sites globally, and we have 35 in Australia with 8 in WA that we run, and a 9th that's going to be starting later this year. So it's promote injury prevention through reality education, enabling youth to recognise risk and make informed choices about activities and behaviours. It's a hospital-based injury prevention programme. It is licensed and evidence-based. Road traffic crashes are a leading cause of death of 15 to 24-year-olds, and alcohol and risk-taking behaviour equals trauma, as we all know. So, summary of the programme: we have a focus on alcohol and other drugs, driving with regards to speed, distraction, seatbelt, fatigue, mobile phone, inexperience, and everything else that goes with that. Planning ahead, knowing what to do if you're in trouble, making sure that talking to them about making plans of how they're going to get home at 3 in the morning if their skipper ends up bailing. Violence, peer pressure, and social media, we touch on all of those as well. So we expose them to the potential physical and psychological. We have photographs, videos. We don't show many dead bodies. You don't need to. Apart from that, you can see with the videos and the photographs of what can happen. We do questionnaires, so we do questionnaires at the start of the day, we do them at the end of the day, and we send them out to the schools at 3 to 5 months, and it's just looking at how their attitudes have changed over time. It's aimed at year 10, 11, 12, so your 14 to 18-year-olds that are coming through. If they've had any recent trauma, we advise them not to attend because it can be traumatic. And as Michelle said, we've had over 18,000 participants through to the end of last year. We would have had 19,000 this year, but I don't think we're going to get it with COVID. So we need, before the school attends, we need full consent from principals, parents, students and teachers to not only attend the day, but for if their parents want them to do the pre and post questionnaires. We run every Wednesday in school term. We have about 30 students coming through. The limit of the 30 is that we go around to try and find patients in the hospital who have been through some sort of trauma, and it can be intimidating having a group of 15 because we split them into 2 groups. So it can be intimidating for the patients having 15 students in front of you, having to retell your trauma that you went through yesterday or whenever it was. 2 to 3 teachers. If one faints, then a teacher will end up staying with the student in ED until they've been discharged. So as I said, we do the questionnaires in the morning. There's different speakers coming to talk to them. We have St John's Ambulance, Head West, which is now Synapse, drug and alcohol. We go on the hospital tour. As you know, we go to ED. It alternates between the registrars and the nurses. Apparently you're in a competition for how many you get to faint each time. Not sure who wins. ICU, the SDN up there tends to do the talk for us up there. We try and find a patient who's been through some sort of trauma, whether it's their fault or somebody else's, in the 15 to 24 age group, who's preferably male, so that they fit all our stats. We don't have people who are involved in police chases, who are deliberate self-harms, and that sort of thing. So it does cut it down quite a bit of what you can pick, unfortunately. So we get with ICU, we'll get the consent from the next of kin, which can be quite hard because obviously it's a tubed patient, can be quite hard for the parents to want a group of students going around to see your little Johnny and lying in the bed, regardless of whose fault it is. Trauma will get the patients to actually talk about what they're doing, and orthopedics, it's the same. We'll try and find a patient who's been talking. Your head injuries, we don't really want them to see the head injuries afterwards, because it can be quite confronting to see a head injury with all the confusion and everything else that comes with it. We will see the head injury in ICU tubed, but not after. Try and avoid them afterwards. In the afternoon, they have a physio session, so they have a go in the wheelchairs, have an idea, well, give them some idea of what the paraplegics go through, opening doors, doing the tricep dips, riding along an uneven surface. Then back down to here in the afternoon, and they have injury prevention ambassador comes in to talk to them from PBS, Paraplegic Benefit Fund, about what they were going through to get their injury and the impact it has on them with the whether they're quadriplegic or paraplegic. Twice a year we have Jonathan Beninka come through from Right Track. He's over from the Eastern States. He was hit by a train when he was pissed, what a surprise, and talks about his injuries. He was the lucky one that survived. He's got an below knee amputation, above elbow and fingers on his other hand. So he talks about what he was doing and the trying to make them think more when they're going out and about. And then we do a debrief in the afternoon with post questionnaires and give them a contract for life. The idea being that once they go home, talk to the parents about what they've been doing, and then we'll contact them in the future if ever they need help. But in the same way, when the parents are out partying and going to parties, that they can contact their child and get them to pick them up from their parties. Works very well in my house. We talked to them about how they're going to get here in the first place, whether they're up in the Kimberley, down in Esperance, or anywhere in between. We talked to them about the cost. Your $900 ambulance bill if you don't have your private health insurance, whichever way you're coming in. Cost of an RFDS flight from Kalgoorlie to Perth one way is about $12,000. So obviously it's a charity-run organisation, but it starts making them think about the cost of this injury in the first place and how long it's going to take them to get here from the regional areas. Your 15 to 24-year-olds, 81% male, 19% female. This is for last year, so it's making them think, what do males have that the females don't, that's making their stats up there every time. It is the testosterone, but it's some of the answers that come out are appropriate. Causes, your 15 to 24-year-olds, you've got 33% with your MVCs, at 24% with your MVCs. You've got your 7% with your pedestrian, 4% with your push bike. So a lot of it is road trauma. So the focus on the day is road trauma, but you've got everything else coming in. So this is where we'll touch on your violence. It's usually the male that it happens to. It is literally one punch. And yeah, that's with your 10%. And again, that's more or less the same each year. Your morning presentations. Oh, it's working. Okay. So that's just a Canadian video with your mobile phones. You can then talk about your mobile phones and the impact of your mobile phones for them. And yeah, and how fast an accident happens once it starts, there's not a lot you can do about it. Driving, if you're driving 60 Ks and pick up your phone to look at a message, not looking at the road for 3 seconds, you're driving blind for 30 metres, so they don't notice what's coming up in front of them. I'm going to skip the next video. So this is making them think about it. You've got your GoPro, there's nobody else around, you can see how far away the beach is. Private property, what sort of injuries you're going to get. So it's a bit like Blackridge Wall here. We're not saying don't do it, just don't do it on your own. Make sure there is somebody else around, so if it all goes wrong, there is somebody there who can call help. Might not work, but there is somebody else around. He survived. He had broken legs, scratches, grazes, the usual. But 10 people have done this before him who have died. So you might be the one that survives, but you've got to take into account your wind. If there's a slight breeze and you get blown into the rocks, you misjudge when the tide's out, and when it's in, you're going to get you more injuries. So it's thinking ahead of what the consequences could be and what could happen. Like I said, we don't show dead people. You don't need to, you get the ideas. At the end of the day, we talk to them with mobile phones, making sure they've got some form of ID. If you're going out for a run, you don't have your ID with you, but you always have your phone. So your iPhone 5, making sure that you've got your little health app updated with all your details. Obviously, they're still in the bitchiness of high school, so we don't want them putting on their medications. If they're on antidepressants or contraception, then that's confidential. It's not something you want other people finding out. Obviously, we want their photograph, we want their name, and I want 4 next of kin. Mobile numbers, landlines, work lines, and put their allergies and reactions on if they've got them. At least then we can start once they get here. Explain to them how you can access that, and if I can access it, then they can all access everybody else's. Once they leave the bitchiness of high school, you can then put in all the other information that you want to. They'll also ask you if you want to be an organ donor, and we talk about Donate Life as well. Oh, perfect. So we talk about organ donation and how it works. A lot of them are 16 that are coming through, so they can apply for it, but they need to make sure their next of kin know exactly what they want doing with their organs. When they're talking to the next of kin, find out what the next of kin want doing with their organs. Talk to the siblings, find out what they want. Take organs up to the age of 70, so talk to your grandparents, find out what they want, but make sure everybody knows what everyone wants doing with your organs. It makes our job a lot easier if it ends up being asked. Juvenile justice come through once a month. They have already been gone through the court system, picked up by the police, attended court, and part of their court order from the magistrate is to attend party day. So it's slightly different from the schools day. It tends to be a smaller group. We have 20 on the list. They don't turn up. They have 3 times to attend, and if they don't attend by the 3rd date, then they get referred back to the magistrates. Usually about 13 of them on a good day. It's on a Friday once a month, and the JJT officers will come in with them. We have a family impact speaker that talks to them with this. We don't go to ED because it's too much pressure doing it twice a week for you guys. They don't do physio, they don't know each other at the start of the day, so they certainly won't get involved with the physio either, and it finishes about 1:30. Outreach, we go out to schools and do a 60-minute talk. We can do it to a larger group. So if they can't come in, then we'll go out to them, and it's just the metro schools that we can do it with. You might get your care schools that aren't appropriate to come in here, and your groups from your PCY, so your police community youth centres. So we'll go out to those as well. Like I said, condense your day to 1 hour. We will go in, and they can have PBF and sign-ups go in at different times to talk to them as well. They can get St John's in to do a first aid session as well if they want to, and do it over a course of a month or something. We will go out to regional areas as well, to potential party sites. So Broome was supposed to be this year, but COVID finished that off. So hopefully next year we'll be able to go out to Broome and try and start a party programme up in Broome. We have Albany, Bunbury, Bustleton, Katanning, Kalgoorlie. Geraldton started this year. Fiona Stanley is going to be the 3rd metro site. We also have Midland. So us and Midland run every week, and Fiona Stanley will do 10 a year. And then hopefully after that, we'll get to Broome as well. Staff programme was supposed to be next Wednesday, but it's next year instead.
Thanks, Kath, for telling us about your program. I don't know whether has anyone done the ED bit of the party program before? Just a couple of nods. It's like essentially from our point of view, we take them through like an ABCDE approach and go like, these are the things that we could potentially do to you if you came in as a major trauma. And there is a competition to see how many people faint. Yes. I don't know who's winning. All right, now that we've had a look at our injury prevention program that we have in this hospital, I'm going to go through the evidence for it. There's 2 major papers. Obviously, you can see there's a lot of names here because the biggest paper belongs to this hospital. I feel a little bit silly sort of presenting somebody else's paper back at them, But I think it's important for us to know why we continue to have this program. It's stuck around for many, many years, and it has been emulated internationally and also nationally. Our first paper is a little bit older, so it is a 2012 paper, but it looks at quantitative evidence rather than qualitative evidence. And so it's more able to comment on observed behavioral change. While the second paper, while it's got more numbers in it and it's more specific to the target risk group, is qualitative in nature. So it sort of like looks at questionnaires and whether there's decay of knowledge in sort of questionnaire responses over time. And so it's probably more able to assess reported behavior than actual behavior. There are some, so this is not the only two papers that we have for the PADI program, and the PADI program, like specifically like .tm, is done in many other countries. A lot of the other papers come from, say, Canada is another one with qualitative and quantitative evidence, but their papers are quite old. I think they're from like the 2010, 2011. So this is still the most recent quantitative evidence. And the other ones are from Germany, and they have quite small numbers, and they look at qualitative evidence. And so the qualitative stuff, the best one is still the Alfred paper, which is the next paper. And we'll go through those papers. All right, so the first one is the effect of an injury awareness program on risk-taking behaviors and injuries in the JJT, so juvenile justice offenders. I understand that this group was chosen as the group to test with the previously identified risk factors because we were more able to follow up on quantitative outcomes. If you have a group of high school students, it's difficult to gain access to consent to look at their justice documents after the program. And I think that like the ethics committee approved JT, and it would sort of like use the data to extrapolate to our target risk groups. So as you can see, it's a retrospective cohort study. It looks at 3,434 juvenile offenders versus the 225 that were referred to the PADI program over 2006 to 2010. In terms of outcomes measured, looked at data that was obtained from the WA police for traffic, drug and alcohol and violence related offences. And also data obtained from the Department of Health for all hospitalizations that were related to traffic accidents or violence. The incidence of the subsequent offences and injuries in those who attended the program compared to those who had not. Now, in our heads, we're probably going like, well, there's lots of different reasons why people might have like violence-related offences and traffic offences, and not all of them are related to only attending an injury prevention program. Like maybe you live somewhere where there's a lot of violence, or like maybe you are of an ethnicity that's like has a bigger representation within the justice system. And so all of these factors were adjusted via propensity score, and the propensity score was sort of like represented the probability of an offender being selected for the injury prevention program. And this was based on age, gender, ethnicity, the number of offences prior to the study, and also socioeconomic background, which they used postcodes to adjust for. The median follow-up for patients was 33 months. So within 33 months, did you reoffend or like have a road traffic related offence or omission? And these are the results. So as I said before, you can see that the 3,000 odd on the right hand side and the 225 were referred, not referred to the program. And then looking at outcomes from data, so not from reported behavior, but from data. And then the results are as follows. So the outcomes are that for subsequent traffic and violence related offences, this was lower for those who had attended the program compared to those who had not. it's like a 3.6% versus a 26.8%, which is obviously quite a big difference. In fact, the absolute risk reduction is 23.3%, and the number needed to treat is 4.3. So it works. The same for injuries relating to hospitalization. This is like a bit of a small difference, so it's 0% versus 1.6%. And for alcohol and drug-related offences, it was 0% to 2.4%. So nothing versus a little bit. When the multivariate analysis was conducted, it found that only the party program attendance and also a higher socioeconomic background were associated with a lower risk of repeat offences. And with the sensitivity analysis, that they recalculated it after excluding individuals with previous offences, and also recalculated it to adjust for ethnicity. So they did only Aboriginal patients or only non-Aboriginal patients, and the results remain unchanged. So the only two things that affect your likelihood to reoffend, have an injury, or have hospitalization related to road traffic or violence is the same. And only a higher socioeconomic background other than a party program was a factor. Good. And the next thing is that it's also cost effective. So remember, the next bit of the evidence chain is whether things are effective and whether it's cost effective. So the program has prevented per year 0.8 serious injuries resulting in hospitalization. It's prevented 0.068 deaths and 10.8 offences over 4 years and 10 months. So the preventions per year, and then that's the complete duration of the study. So if there were a lot of numbers in here, but I took the calculation for the post-hospitalization costs of injuries. So per offence prevented, it costs 1,826. The cost per serious injury avoided is about 24.5 grand. And the cost per life year gain, which is discounted, so as in like earlier years are more valuable than later years, which is the 3%, which we'll just forget about the ethics about that, but never mind. This is how we do it. It's 10.5 grand. And this is like really good and very much comparable to other preventative screening programs that we accept as good. So for example, the cost per life year gain, which is discounted for breast cancer, is 24 grand, and we think that's fantastic. So this is more cost effective than that. Now, this is all great and that, but admittedly, this involves a cohort of juvenile justice offenders, and whether this education program is equally effective for young people who have not committed an offence is uncertain, but we'll look at another paper that addresses that. But this is a qualitative paper. This is the next centre that adopted the party program outside of Canada. So it came from Canada, Monica got it here, we got it going here, and then the Alfred started it. And the Alfred had a look at everybody who attended their program for senior school students, so actually the target group, for age 16 to 18 who attended the program from 2011 to 2016. And they had 2,505 people. So the way they conducted the study is that the same way we do our surveys here. So we gave a survey at the start of the day, a survey at the end of the day, and then another survey at about 3 to 5 months, where it's sent to the schools and teachers would distribute them and then like get the surveys back and then process the results. Of the 2,500 students that attended, they only got about half of all the surveys back. So that's 1,300 and something, which is a 53% response rate. Annoyingly, female students were more likely to complete all the surveys and then give it back than male students were, but we'll just accept that for now. And of those people who they had complete surveys for, 68% of them had a learner's permit for driving. The primary outcome measures that they were looking at were the likelihood of driving after alcohol, the reported likelihood of driving after alcohol, the designation of a safe driver after consuming alcohol, the perception of an injury if involved in a motor vehicle accident without a seatbelt, and the perceived likelihood of injury after risk-taking activities. So the results are this. So the like numbers on the right-hand side, and then the chart is, I can't do right and left, but you guys know what I'm trying to talk about. The chart's on the other side. And so the first one is the first survey. The first point is the first survey. The second point is the second survey. And then the last point is the 3 to 5 month survey. And then that's like a percentage of people who had the reported risk, essentially. So the first top point with the like dash orange dot line is the participants who reported definitely not to drive after drinking alcohol. And you can see that it's 86 and a 94, and then after 3 to 5 months, it's still pretty high at 93%. The second point is designating a safe driver after drinking, which I put down as DD, which is still pretty good. So a lot of people would before, still would, and then still would after that. The third one, which is that like the dot line, is the perception of sustaining a definite injury in the setting of a motor vehicle accident without wearing a seatbelt. And so a lot of people just went, nah, I'll be all right. And then like, oh, actually, maybe I won't. And then after that going like, actually, maybe I will be all right. And the last line, which is the solid line with the orange dots, is the perceived likelihood of sustaining an injury after risk-taking activity. And then people are just like, I will definitely be okay. Maybe I won't be okay. And then like, I would still do it and still be all right, I think. So what that demonstrates, I guess, is that, actually I want to go back. I can still go back, all right, cool. So there are improvements in the perceived likelihood of not driving after drinking alcohol and the inclination to designate a safe driver when drinking, and that shows minimal decay. So like the numbers are still pretty high, even after 3 to 5 months after you've gone through the PADI program. But for like the next two bits, which is the perception of risk regarding seatbelt safety and the injury associated risk taking, that's got pretty significant decay in like your perception of like what will happen to you. So the question is whether we need to reinforce it. Like, does the PADI program have, should it have like a follow-up in the like next 6 months? Because the entire point of the program is just like, we know that these people are at risk, but they're at risk for like a reasonably short time of their lives. So you just need the program to get them through this risk until you grow up and become less retarded. And like that's what you're trying to achieve, right? So whether or not we just need to reinforce this a little bit more, but at the same time, like, and the question is whether other things change those numbers, because the alcohol-related figures don't show decay. But whether or not this is because there's other messaging, because there's like quite a lot of community messaging about, you know, having a DD, not drinking and driving, and so it's not specifically a PADI program. There's lots of community initiatives that like target this thing. So whether a lot or not, there's like not decayed, not because of specifically a PADI program, but there's other things that play here. And obviously, like, this is also only reported behavior. Like, this is what we're trying to extrapolate what will actually happen, about the decay of their knowledge, but it doesn't actually comment on behavioral outcomes. Whereas the first study we went through was quantitative data that says that yes, behavior does change and the change is sustained. So given that, like, you know, there is a change in behavior, and there is in our target group, there is like a change in reported behavior or reported inclinations or probabilities. We could say that this would be a proxy for behavioral change, but okay. And so those are results. The take-home message from the stuff that we've gone through today is that the burden of road traffic injuries is significant, and the majority of it is borne by young people and predominantly men. A part of this can be explained by a higher likelihood to partake in risk-taking behaviour. The party program is an effective harm minimisation strategy attempting to address this particular factor in the many factors that we have for crash involvement. And there is a decay in risk perception, but overall there does appear to be a measurable behavioural change that can probably be extrapolated to our particularly risk group and our target audience. And there's no references. Thanks, guys.
Thank you very much, Michelle. Every time I see these sorts of numbers, I always feel like I need to apologise on behalf of my gender for causing all this trauma, and also probably not for filling out all the forms correctly, which I know I don't do. Time's a little bit short, but if anyone has any questions for Michelle or comments regarding the prevention program in general, would be. All right, we're all good with prevention. Excellent. All right, thank you very much. Will you all join me in thanking Michelle again? Well, the only question I was going to say is when are we going to reach that? I didn't think
second week of the so this will be ended. So 34 restrictions were lifted.